Dear colleagues, I'm very happy to see you back again here. So my name is Sara. I'm from Portland, Oregon, and I studied in Debrecen. I work in the cardiology hospital. I love Hungary very much. That's why I'm here. I would like to thank all the Translational Medicine Institute team, including my statisticians, Dr. Durai, my supervisor, Dr. Hegi, and my SMS, Marie, for their incredible work, support, help in every stage of our research project. My vision is introducing innovative approaches in medicine through translational research from bedside to bench and bench to bedside for my patients all over the world. And my mission is collaborating with Semmelweis University Cardiovascular Medicine as a natural leader in health for purpose of improving the health and well-being of Hungarians and beyond. I have a clinical questions about leadless pacemaker, and my methodology is comparing rates of complication in leadless versus conventional pacemaker for right ventricular pacing therapy. And the second one is real-life patient selection and indication of leadless pacemaker as an international survey study. As a background, leadless pacemaker is less invasive with fewer complications. The primary advantage of the leadless pacemaker is elimination of several complications associated with conventional pacemaker and leads, including pocket infection, hematoma, lead dislodgements, and lead fractures. It's only for single chamber ventricular pacings and lacks defibrillation capacity. It is 90% smaller than conventional pacemaker, and it has a cosmetic appeal. And the future of the leadless device technology is promising, and one of the beneficial effects of it, application of it, is in the post-TAVI patient. This is a future perspective of the leadless pacemaker that we use combinations of the leadless and conventional pacemaker in a patient. About my first projects, the pacemaker-related infection is one of the most costly complications and has very high mortality rates, 30 to 35%. In one paper, there is no mortality difference between leadless and conventional pacemaker. And leadless pacemaker were designed to reduce lead-related complications. Articles suggest that they are associated with reduced infection rate, dislodgement, but a higher tamponade rate. That's why the systematic review is needed. The clinical question is that, is the leadless pacemaker use associated with different rate of mortality, complication, and revision compared to conventional pacemaker? And the PICO, the population is patients who need pacemaker for right ventricular pacing. The intervention is leadless pacemaker therapy, and the control is conventional pacemaker therapy, and the outcome is all-cause mortality, complication, revision, infection, and cardiac tamponade. And the hypothesis is that the leadless pacemaker has less complication than conventional pacemaker for right ventricular pacing. We used the following databases in November 2nd and the following search keys for our research. And we found 126 articles, including only leadless and comparing leadless and conventional articles. So as a finding, we focused on 1 month, 6 months, 12 to 24 months, because in these months, usually in conventional pacemaker, we have more complications. So that's why we compared leadless with conventional throughout this timing. And as a result, as you see in these articles, the heterogeneity is 97%, and the odds ratio is 0.58, so it means that 42% we have less complications in the benefit of leadless pacemaker. Also, I just wanted to show you that, for example, in Cantillon and Pettini articles, in Cantillon articles, we have the patients with less comorbidities compared to Pacini's, that we have patients with more comorbidities, so they are more sicker in Pacini's article. And in the 6 months complications, as you see, the heterogeneity is 0%, and the odds ratio is 0.84%, so we have 16% less complications in the favor of leadless pacemaker. So it's clinically relevant. And in complications 12 to 24 months, we have heterogeneity of 0%, and odds ratio is 0.33%, so we have 67% less complications in the favor of leadless pacemaker, so it's clinically relevant in this case also. In the case of all-cause mortality for 1 month, we created the table. So it's 3.78% in the favor of conventional, but also the leadless is 4.26% in 1 month. And for 6 months, as you see, the heterogeneity for all-cause mortality is 0%, and the odds ratio is 1.21. So it means there is no difference between leadless and conventional pacemaker for all-cause mortality in 6 months. For infection for 1 month, we see that it's 0% almost in the favor of leadless pacemaker, so we have no or 0% of infection. In 6 months, also it's 0% in favor of leadless pacemaker, and in 12 to 18 months, 0% in the favor of leadless pacemaker, so no infection. So as a summary, the strengths in our study is for some of these outcomes, we managed to pull a lot of patients, 10,000 patients, and these are all from direct comparison studies. The limitations is that these are all observational studies, and some of them applied historical cohorts, and the strength of evidence is not that high. And the low events rate for some outcomes do not allow for meta-analysis. As a conclusion, in terms of complication rate, leadless pacemaker seems to be better in lower complication, with a lower complication rate. And for all-cause mortality, it didn't show any difference. And as a summary, in clinical implication for practice, patients with higher risk should receive a leadless pacemaker because leadless pacemaker has a lower complication rate. An implication for research, more studies are needed, if possible, in the form of randomized control trial. And in the second study, we already created the preliminary questionnaire that we will send it to networks of our arrhythmia societies. And basically, the questionnaire would be focusing on that why they don't use or why they use leadless pacemaker in their centers. And then I will update you with the outcomes. So these are the summary of my projects, and thank you for your kind attentions. As my hobbies, I always, one of my hobbies is writing the poems. Since the spring is coming soon, so my personal quote is, having a spring in our hearts and hearts, and every heartbeat is a gift, and its pattern is universal. Peaks and valleys, ocean and waterfalls, evergreen trees and falling leaves, rise and fall, beat after beat, or heartbeats, translating this message that we are here, we are alive, they are the melody of our lives. I'm wishing you all a very happy and healthy spring. Thank you very much.
Thank you very much, Sara, for this wonderful presentation. I'm just curious whether, is there any, what is the reason that there are no randomized trials for the leadless conventional comparison? I mean, there are a lot of single-arm studies yet that you found. 6 or how many were direct comparisons, and the rest of them were single-arm studies. Why? So there are many single-arm studies. What is the reason for the lack of randomized trials? This is the question.
Why they are not doing the randomized trials?
Not you in the literature.
I'm not sure why they don't have it, because maybe it's because it just approved on 2021 the usage of the leadless pacemaker. Maybe probably they will start it. They will start soon, but I'm not sure why it does not exist, because it's a pretty new technology. They started to use, the FDA approved it on 2021, and hopefully in 2022, 2023, they will start it, or they will think of it. But that's all I can think of it.
Okay, thank you.
Thank you, Sara, for your presentation. I have 2 questions. First question is there a criteria? I don't know if you answered my question already. Is there a criteria for those patients who should receive leadless pacemakers or conventional pacemakers? And my second question is, I could see heterogeneity 97% in one of the outcomes, and sometimes it's 0%. Do you have any reasoning for that as well?
Yeah. So I will show you this. For example, in these articles, every single center decide that what are the criteria for their patient to receive leadless. But because it was quite new technology, they decided to mostly they used the patients who are above 79, the majority of the patients who receive, or they should have a very strong reason for having it, because they wanted to see if they have so much of comorbidities, still can they benefit out of it, and because they didn't want to risk, probably. They didn't want to risk, so they used very high comorbidity patients, 79 above, with lots of other complications, like as you see, lots of complications they may have, but still they wanted to see if they have less complication or they can benefit out of leadless by doing it. And then they will get more confident to use it in the other patients who are more healthier with the lower age. But so far it has a good success in this term. And the second question?
For the heterogeneity, sometimes it's 97%, and in some outcomes it's 0.
Yeah, because the selection group, the groups are so in different studies, different criteria for giving them different comorbidities criteria. So that's why. But as always, Dr. Hegi always says that life is heterogeneous, so it's okay to have a high heterogeneity. So yeah, but the comorbidities was different, and the patients has different criteria for receiving in different studies. Yeah.
Okay, thank you.
It's an interesting study, and my question may relate to the last question, that as far as I understand, that the leadless pacemaker has not the capability to defibrillate. So, and I just assume that the indication of the 2 different pacemakers should be then different. And how can you compare these 2 groups if there are so big differences between the reasoning of applying these devices?
Thank you very much for your questions. So all of these studies comparing the leadless, the patients who needs right ventricular pacing with the patients who receive conventional pacemaker for the purpose of right ventricular pacing. So basically, none of the conventional ones had a defibrillator. So in that term, it's equal. So they were comparing the same kind of patient that they need right ventricular pacings, either for leadless and for conventional. So defibrillator was not here a part of the whole study.